I'm Al Charbonneau, the Executive Director of the Rhode Island Business Group on Health. Thank you for joining us in this important discussion. Are you ready to reopen your business? I'd like to begin by thanking our sponsors who support the sharing of this information. I know I speak on behalf of the RIBGH board when I say we are eternally grateful to our platinum sponsor, Mercer, our gold sponsors, Blue Cross and Blue Shield of Rhode Island, Hilb of New England, United Healthcare, Neighborhood Health Plan, Tufts Health Plan, and Aetna. Our silver sponsors, USI Insurance Services, Merck, Novo Nordisk, Gallagher, and Delta Dental. And equally importantly, our members, a growing group of 90 plus companies in Rhode Island representing over 80,000 employees. I also know that I speak on behalf of the RIBGH board when I say thank you to the Health and Productivity Committee that is responsible for today's event. The H&P Committee is co-chaired by Robin Bouvier from Aon and Jean Tapley from Anika Insurance. I also want to thank Joanne Bellata and Erica Collins for organizing today's event. It is my pleasure to introduce Robin Bouvier, Vice President Health Transformation for Aon and co-chair of the H&P Committee. Robin will introduce Dr. Ray Fabius. Robin?
Awesome. Good morning. Thank you, Al. I appreciate that kind introduction. I also want to reiterate how thankful I am to the Health and Productivity Committee for all the work that they've done over the course of the last year. Normally, we would be getting together the second week of June for our annual Wellbeing Summit, but because of the pandemic, we are modifying our approach and we will be facilitating a number of webinars on different topics over the course of the next couple of months. The first of those webinars is today. I will go ahead and introduce our speaker in just a couple of moments. Next month, we will be getting together to talk about helping people thrive. And then in June, we'll be conducting a session on a recovery-friendly workplace to help address the issues around substance use disorders across the state. A couple of quick housekeeping items. As you have questions during today's presentation, please use the chat feature to go ahead and type those in. I will moderate the questions and have Dr. Fabius respond to them after he has concluded his presentation. At the end of the presentation, you will also receive a survey, and it will ask you for some information about your experience today, as well as topics, dates, and times that you would prefer for some upcoming events. So we really appreciate your feedback. If you'll take a moment to please complete that. Also, we will be posting Dr. Fabius's presentation as well as his complete bio on the RIBGH website. So you won't have to feel overwhelmed taking notes during today's conversation. And if there are too many questions for us to answer before the top of the hour, we will type those up and post a Q&A as well. So without further ado, I would like to introduce my friend, Dr. Ray Fabius. We actually met back in 2012 when he was a part of the faculty of Harvard School of Public Health and conducting a presentation on integrating health and safety. So it's very nice to have him back. You may recognize his name and face because he was also one of our keynote speakers at a Wellbeing Summit that we conducted back in June of 2016. So welcome back, Dr. Fabius. Ray has over 30 years of successful business experience in leadership as a global physician executive. And he's specifically going to talk to you today about the roles that he has played as the global medical leader of General Electric, as well as the chief medical officer of Thomson Reuters. He has also played corporate medical leadership roles at both US Healthcare and Aetna, and he is currently with an organization that he co-founded called Health Next. And we learned a little bit about Health Next and the work that they're doing around driving cultures of health within organizations and how important that is to a thriving and healthy and high-performing workforce. So I will, without further ado, go ahead and hand over to Dr. Ray Fabius. So thank you, Ray.
Thank you, Robin. It's a delight to reconnect with both you and Al. We both have a long, I'll say, friendship, and you know, we have been co-conspirators in this movement to try to make companies healthier and more productive for many, many years. So this is an opportunity to rekindle that passion together. but also to speak specifically about what employers can do to face this remarkable challenge. As Robin, you alluded to, the real reason why I have become an expert in this space is because soon after I accepted the position as the global medical leader at General Electric, SARS broke out. And I had 60,000 GE employees in China and Southeast Asia who were in harm's way. And we had to find ways to respond to that epidemic. Many of the things that we did at that time, along with other global medical leaders, are commonplace today and actually are being effectively utilized during this pandemic, including the attestation questionnaire that most employers have asked employees to complete before entering the workplace. Asking questions like, do you have a cough? Yes or no. Do you have a fever? Yes or no. Have you been around anybody who has a cough or fever? Have you had any known contacts with COVID? And if the answer to all those questions are no, then it's safe to enter the premise. That was a concept that we actually came up with in the that 2000 and I'll say I think 2006 period. Let's dive into this challenging pandemic that we are all facing, and my hope is to really provide you with a deep understanding of all the knowledge that we have so far, so that you'll be better equipped to not just make decisions today, but into the future as more information becomes available. It seems like a long time ago, but actually the virus was identified just back in December. And the first case was reported in the United States on January the 21st. And like many of you, I keep abreast in part of what we know about this virus by referencing the CDC website, which is an excellent source of factual information, as well as the World Health Organization's sites. We also know that largely this virus is transmitted through respiratory droplets. Secondarily, you can actually get the infection by touching a surface or touching a person where there's live virus present on that surface, and then touching your eyes, nose, and mouth. What's really important to make clear to everyone is the virus, thankfully, cannot go through your skin. So touching a surface with a virus on it will not get you infected. There is a second step that's required, and that is that you need to take that hand with the virus on it and touch your eyes, nose, or mouth. That's the reason why we recommend, for starters, that you keep your distance from someone. Even in a sneeze or cough that's not covered will normally have respiratory droplets travel 3 feet. If you're 6 feet away, you're beyond the sphere of those respiratory droplets. Obviously, if everybody's wearing a mask, it's much less likely that you're going to have an experience of being around somebody with an uncovered cough or sneeze. But it's very important to make it clear to everyone that wearing a mask does not substitute for physical distancing. Also, I'd just like to make a pitch that we not use the term social distancing. We need to be connected. Even this morning, where we're all on a website together, is a form of connecting. So important for all of us as human beings to be socially connected, but we do want you to keep your physical distancing for now. There have been excellent studies done of people at work using video technology. The average person while at work touches their eyes, nose, and mouth 16 times an hour. 16 times an hour. So this idea of trying to get people to stop touching their eyes, nose, and mouth with an unwashed hand is actually a remarkable challenge for all of us. Unconsciously, we're fidgeting with a small itch in our eye, or some the perceived dental issue all the time. So perhaps one of the silver linings of this pandemic will be that we can all work hard to break that habit. And it will pay dividends for us throughout the rest of our life, especially during seasonal flu season. So what we want to do as we return to work is to maintain messaging around wiping down common surfaces frequently, keeping your social distance, wearing a mask, and it is really important to try to train all the people on your staff about the importance of not touching their eyes, nose, and mouth. We all know the symptoms that have been recommended for us to be looking for in ourselves and our loved ones: fever, cough, and shortness of breath. However, more recently, many new symptoms have been added to this complex. It is, though, unusual for people to have this condition in any kind of a significant fashion without fever and without cough. But these are some of the other additional symptoms. Interestingly, pink eye is probably because someone touched the surface with live virus and then touched their eyes. But I've actually personally case managed elderly people in particular through COVID-19, and they have reported to me all of these symptoms. When you return to the workplace, you should have a poster up in every bathroom so people can see what the appropriate way to wash their hands are. There have also been very good videos done studying people's hand washing techniques in restrooms, and about 2/3 of women wash their hands appropriately and 1/3 of men. So once again, there's a gender difference, and I want to apologize for the male gender one more time because they seriously have work to do in terms of hand washing. Remember that you need to make sure that there's soap on the entire surface of your hands, between your fingers, the webbing of your between your forefingers and your thumb, the front and back of the palm. There has to be some rubbing involved across all of those surfaces. There has to be comprehensive rinsing, and then there has to be comprehensive drying. So anybody that runs out of the restroom with wet hands, for example, has not done a good job. I do want to reinforce the fact that the use, I know it's not easy to find, but the use of hand sanitizers is not as good as hand washing. And so that would be a second option. Now, as hand sanitizers become more available, they should be liberally distributed around the workplace so that people can use hand sanitizers between hand washings. But everybody should be, for example, washing their hands before they would enter a cafeteria, and they should be washing their hands before they enter any common area, even like an elevator or a handrail in a stairwell. We're all in this together. One of the reasons why I am encouraged that we will ultimately find, for example, medications that can treat this and also vaccines that can prevent this is that we have, for the first time in a very long time, a common enemy with everyone else on the face of the earth. I can tell you with great enthusiasm that I'm aware of many studies that are going on all the time where universities in the United States are working on finding a cure and turning the research over to universities in China and then in Europe around the clock so that when we go to sleep, others are waking up and continuing to engage in study and pursuit. We also know that this has now spread around the entire country and particularly impacting the Northeast corridor where we reside. I'm calling you from the Philadelphia area. Of course, the epicenter of this disease, this pandemic, is New York City and its surrounds, and we are really not that far away from there. So we are impacted from that epicenter. Sadly, we don't have any treatment yet for this virus, so the recommendation is to just do the same things that you would do for any other flu. Rest, analgesics, and fluids. There is some debate as to whether or not you should only use Tylenol. I would say to you that the rationale for not using other options like ibuprofen or what we call Motrin or Aleve is not very strong. We do know that Tylenol has less side effects, and for that reason is often a recommended first choice, but may not be able to do a good job with pain relief, and so obviously you can contact your own physicians around whether to use other analgesics other than Tylenol. I'm happy to tell you that the vast majority of people who contract this either have no symptoms or they have mild symptoms. And probably somewhere around 10 or maybe 15% of the people who get sick may require hospitalization, but somewhere between 85 and 90% get better at home. And we're certainly learning more and more about asymptomatic cases or cases that are so mild that they may not be picked up. And so as this denominator rises, the percentage of people that we may ultimately believe will require hospitalization may even fall to less than 10%. There are 4 potential game changers. So as all of you are looking at having your workforce return, you have to keep involved with the latest information about any kind of therapies that may be effective. I'm going to say that if there were something that was under study at this point that was dramatically curing the COVID-19 virus cases, we probably would already have heard about it. What I expect is that the studies that are being done right now through many different protocols and meta-analysis may likely come forward and say, this medication has reduced the likelihood that someone may need to go on a ventilator, may reduce the hospital length of stay, but not so dramatically that we would call this treatment necessarily a remarkable cure. You have to understand that what has been studied up till now, it has been existing medications. These are medications that were not actually created to treat COVID-19, but perhaps other viruses. At the same time, there are a number of esteemed biotechnology and pharmaceutical companies designing new medications specifically against COVID-19, and they may take a longer time for testing and approval, but ultimately they may wind up providing greater promise. More likely to be a game changer will be vaccines. There are protocols going on right now with 7 different approaches to vaccine creation. Those of us that have some expertise in this space believe that it is likely that we will find a vaccine that can work. There are at least 3 vaccines that I'm aware of that are already in human trial. This is ahead of schedule. I think we can be cautiously optimistic that we may have something as early as January 2021. Johnson & Johnson, for example, announced that they believe that they'll have a vaccine perhaps available at that time with the capacity to actually ramp up and produce as many as 900 million doses by March. So I think the trick for us right now is to try to contain this thing all the way through till we have a vaccine that works. Now, we may be surprised with an announcement in early May that some of these medication trials are more effective than I'm actually conveying to you. And again, that would be a remarkable game changer. Third line of defense, I'll say from a biotech and pharmacologic standpoint, is the production of antibodies. We do know from the treatment of the last Ebola outbreak that when you take plasma from somebody who's successfully survived Ebola and spin it down and give it to people who are struggling with Ebola, you actually take the antibodies that were produced in the body of somebody who survived and now give it to someone who's struggling with Ebola. And that actually was a game changer in the most recent outbreak of Ebola. We are in research protocols with that same approach with COVID-19, and we're cautiously optimistic that the pooling of plasma and the sharing of plasma from people who've survived may actually be a good therapeutic tool. Also exciting is the possibility of isolating this antibody and possibly actually mass producing it artificially. And so that's under investigation and trial as well. And then the last game changer in our approach to bringing people back to work is the issues around testing. Now, there are two key versions of testing that you hear about, and some of you may have already experienced. One is to take a nasal swab and to see whether or not there's the presence of the COVID-19 virus in the back of the nose and above the throat. In order for this test to be done effectively, you need to, first of all, have a good specimen taken. And you can see from this, schematic that it's actually not that easy to get a swab all the way into the back of the nose. And it's also not very comfortable. But when somebody backs up while the swab's being put in, a good specimen may not be obtained. So step one in the nasal swab testing is to get a good specimen. Then there needs to be good reagents available in order to take this specimen and prepare it for being placed in the testing devices. It requires training in the laboratory to train people on how to use the device, how to use the reagents, and of course, getting the specimen rapidly transferred to a laboratory is also important. If all of these things are not done well, you may get a false negative answer. And so telling somebody that they don't have COVID in the back of their throat when they actually do is problematic. Now, we are telling people that if somebody has a positive nasal swab and then they either have symptoms or not, but perhaps as early as 10 days later, they have a repeat nasal swab and there's no longer any COVID-19 in the back of their throat, that starts to make us feel comfortable that they've gotten over the virus. Some are actually suggesting that you need 2 separate negative tests 24 hours apart, for example, before considering returning to the workplace. An alternative that has been recommended by the CDC is that for any of your workers who have been COVID positive, they should actually not return to work for at least 10 days and also must have 3 days without fever, without the help of Tylenol or some other medication that lowers fever. So both of those conditions have to be addressed. So if somebody is still having fever after 10 days, they can't return to work, obviously. And so if they it takes them 10 days to get over it, and then they have 3 more days without fever, without the help of Tylenol or another fever reducer, they can return to work, even without any testing. This is based on the best scientific understanding that we have. Not much has been said about antibody testing and its potential to identify for all of us whether we have immunity. The gold standard, and some of you may have engaged in this already, to study whether you have an antibody level for anything, is to go to a laboratory and to have a vial of blood drawn from you, which then can be spun down so the red blood cells are separated from the plasma, the clear part, and then that clear part is then studied to see whether there's antibodies in your plasma. That would represent the fact that your body already had COVID-19 and had already made a response. That is the gold standard. It's expensive. It requires the removal of a whole vial of blood, and it takes time to get the result, sometimes as many as 2 or 3 days to cycle through the process. Obviously, there's great interest in having a rapid test. So it's not unlike a pregnancy test, which maybe with a drop of blood could tell us whether or not we have antibodies or whether we have experienced an infection with the COVID-19 virus by having antigens. Right now, the tests that are, I'll say, too rapidly approaching the marketplace have terrific potential for false negatives and some potential for false positives. It should be made, you should all be made aware of the fact that there are cold viruses that are caused by other coronavirus. And so one of the challenges of the rapid test is to make sure that the antibody that we're identifying is an antibody against this COVID-19 and not against a common cold virus that we may have had in the past. So initially, the FDA was allowing these test kits to come forward quickly, but they've reconsidered that because the accuracy of these tests is still not good enough, really, to be used as an effective screening tool. This colored-in box gives you some idea of where COVID-19 fits in relative to other epidemic viruses that we're aware of. And as you can see in this chart, smallpox at the very top is remarkably deadly, like Ebola, and SARS and polio, all more deadly than COVID-19. You can see that it compares somewhat more closely with our seasonal flu, although it clearly appears to be more deadly than the seasonal flu. It is nowhere near as infectious as chickenpox or measles. And again, its infectivity is more closely related, but it does appear to be more infectious than seasonal flu. When you make a comparison of COVID-19 to the seasonal flu, you can see that we are starting to approach the kinds of numbers that we experience in an annual flu season. We suspect that these numbers will exceed an annual flu season as more people get exposed and infected. But those of us who are clinicians and have been eternally frustrated with trying to get the attention of everyone around how deadly the seasonal flu is, may actually have an opportunity to now get people to pay more attention to, for example, not coming to work when you're sick with the flu, to covering your mouth with a cough when you have the flu, with potentially making sure that you get the flu vaccine early. Because, in fact, I'm sorry, I want to go back to that previous slide. Let me see. In fact, as many of you may not know, each year in the United States, there's somewhere between 24 and 60,000 flu-related deaths. So as we approach 60,000 deaths here with COVID-19, right now, COVID-19 is as deadly as a bad seasonal flu, but truthfully, we do expect this number to get much higher on the COVID-19 side But one of the curious things about COVID-19 is it doesn't seem to be affecting children. The seasonal influenza is a much greater threat to children. So if you have young children or you have grandchildren, this would be also another reason to take everything that we've learned from COVID-19 and apply it every year during the seasonal flu. Everything that you've heard about in relation to flattening the curve has really been to make sure that the few people in your community who get very sick and require hospitalization, or even the fewer number who require the help of a ventilator, have a hospital bed and a ventilator available to them when they need it. So all of the efforts that we've engaged in to do the physical distancing, to basically sequester ourselves at home, has saved millions of lives. The original modeling, as Dr. Fauci talked about, and President Trump, which I had a chance to study early on with this, suggested that as many as 2.2 million Americans would have died had we done nothing. And at the end of this, I can quite certainly tell you that we're going to save at least 1 million lives, probably 1.5 million lives, because of what we have done together as a country. So in that sense, we are all heroes in this. The case study of South Korea is really worth looking at. For those of you that are in the business world and are familiar with Six Sigma, the question that's always asked in Six Sigma is there any place on earth that has done this better than we're doing it now, perhaps in our company, and can we go study it and then try to shamelessly copy the things that the benchmark organizations or companies have done? The same approach should be considered with governments and with countries. And so a benchmark to look at is South Korea. They rapidly engaged in testing that was effective, and are now producing over 100,000 tests a day. They tested 40 times more people than the United States by population density. And they gave birth to the concept of drive-by screening centers. As a consequence, they did not really have to engage in lockdown. They had very few deaths. I didn't update this for the present time. It may be as many as 240 deaths now, but they have done a terrific job of what we would call in the science of actual containment. Sadly, in the United States, we didn't engage in containment. We moved very quickly into what we would call mitigation. So after there's a very significant spread, you can't contain it, and then you're left with what we were required to do, which is sequester in place. There is concern as we start to reopen the country that we'll have a remarkable second wave unless there's adequate testing, and we'll talk a little bit more about that shortly. Another good case study that is worth mentioning to everyone, and as ironic as this may sound, there is really only one community that early on was tested completely. It happened to be the people who were on the Diamond Princess cruise ship. This is the only community where everyone was tested with a nasal swab. There were 3,700 people on this cruise ship, and 800 people tested positive. Remarkably, at the time that the test was done, almost half of the people were asymptomatic when they had the virus in their nose. We do know that people have the virus in their nose for a day or two before they become symptomatic, and we do believe that a sizable portion of these people who were asymptomatic when they were tested positive did go on to have symptoms. But it may be as high as 20% of the people who actually test positive for the virus in their nose may actually not have symptoms. There were 10 people who sadly passed away from this population, which is roughly a 1% fatality rate. So if If this number is true, for example, if we have now 50,000 people who've passed away in the United States, we probably have at least 5 million people who've already experienced the vaccine, the virus. And we would say hopefully have developed some immunity. But you can imagine how early we are in this pandemic if only 5 million Americans have had the infection and have developed antibodies. Now, in other studies that have been done, say in the New York area, there may be a much higher number. We may actually have as many as 12 or 15% of the population who've been exposed and have developed some antibodies. But needless to say, even at 15% is just early into this pandemic exposure. Because of course that would mean that 85% of the American population has not actually had the virus yet. So the good news, of course, is that we've successfully sequestered. We flattened the curve. The bad news is that we still, until there's a vaccine, the only other way to actually get through this is through what we call herd immunity. And after 60, 70, perhaps 80% of the population gets antibodies through natural immunity, will we see this virus perhaps disappear? So I want to comment for a minute on seasonal flu. The reason why seasonal flu goes away, quote unquote, when there's warm weather is because it comes to us in September. And then we get sick from seasonal flu in September. Some of us get sick in October. Some get sick in November, December, January, February, and early March. And by the time the virus has hit enough of us, we develop enough antibodies in the community so that there are very few people who haven't had it, and then the virus goes away. In fact, it dies because the virus can't really live if it doesn't have a chance to reproduce inside of us. So generally speaking, the seasonal virus does not go away because of warm weather. It goes away because of herd immunity. Here's just I'll say, an overriding, perhaps silver lining from the COVID-19 pandemic. Many of us, like Al and Robin and I, have been trying so hard to get the attention of as many people as possible around population health. This is a team sport. It is certainly true that someone can embark on losing weight successfully and perhaps even keeping it off. But it's much more likely that you'll be able to lose weight if everybody around you is also trying to lose weight and exercise and engage in healthy lifestyles. What this virus has taught us is that if you are taking care of yourself, you're much less likely to contract the virus, and you're much more likely to deal with it successfully without serious repercussions. For those of us who are smokers, there's now a new reason to stop smoking. And I think for those of you that are employers that have smoking cessation programs, this is now a new reason to promote your program. We do know that people who smoke have at least 3 different reasons for a much greater risk of unfortunate consequences from this COVID-19 virus. One of the reasons why it's hitting Italy so hard is because of the remarkably high incidence of smoking in that country. It still remains not just socially acceptable to smoke in Italy, it's socially promoted. And so we need to embrace cultures of health and well-being, and if for no other reason, to become much more resistant and resilient to COVID-19. Health Next has been helping many employers build cultures of health and well-being, benchmark cultures of health and well-being, and my clients, employees and their family members are faring better than the average as a consequence. So for those of you who have employees, large and small, who may have hypertension or diabetes, this is also a reason to make sure that those people are getting their high blood pressure and their diabetes under control, so that if they contract this COVID-19 virus, they'll be more resilient and be able to handle it well. All right, let's talk specifically about reopening. As I talked about, when the numbers in your community start to go down in terms of cases, and the recommendation is to consider reopening no sooner than at least 14 days of diminishing cases in your county. So you have to pay attention to what's going on in the county where you are located, and perhaps in the surrounding counties if your workers actually live in the surrounding counties outside of the county where your workplace location resides. But if it is true that in those counties there's 14 straight days of decreasing caseloads and your state is saying that it's okay, it is a time to consider reopening your office. Now, at the same time, it is, I'll say, important to be in contact with the local public health representatives, even at the county level, if they exist, to see from their standpoint whether they believe it's reasonable for you to reopen. Obviously, all the workplace mitigation efforts should be maintained, and there should be very strong reconsideration for allowing workers who are at least over 60, and I would say even over 55, to continue to sequester for a longer period. I want you to be thinking about incubation periods. So the virus actually incubates inside of us for perhaps as long as 14 days. That means that you can be exposed to somebody who has COVID-19 and not actually get sick for as long as 14 days. So the reason why we're recommending that you shouldn't reopen until the case numbers are consistently going down for 14 days is because that's a full incubation cycle. If you are wanting to be even more careful, then you might want to think about an incubation period and a half, or 21 days, or 2 full incubation periods, 28 days, which actually I would recommend for any employer who has successfully made the conversion to having their people successfully working at home. I understand that that doesn't work for companies that are in retail, but the longer that you can put this off in your county, the easier it will be for the public health officials to do the testing of people who get sick and the contact tracing of those people, in the hope that they can effectively contain the virus so there won't need to be a second wave of sequestering. Those of us that are experts believe that there's a reasonable possibility that we're going to be asked as in many communities, if not the whole country, to go through a second sequestering. Certainly if there's a second wave of this virus before a vaccine gets constructed. In particular, I want to talk about the concept of pod construction. You should, as you reorganize and have your workforce come back, organize in a way that if someone actually does contract COVID-19, it doesn't wipe out a whole department. So that people should be working in groups, in small groups, so that when someone comes to contact trace a positive case, you can tell them that these are the only other 4 workers that the one worker was exposed to. It's very important as a consequence to perhaps consider staggering your workforce, having perhaps longer hours of work, but less people at the workplace at any one time. And obviously, as you have probably already done, making sure that there's good cross-training especially of essential workers. In order to reopen, this minimum of 14 days of sustained reduction in cases is the first criteria. The second criteria is to make sure your local hospitals can accommodate patients, and they're no longer stretched for resources and beds, and I put this at the bottom, but probably should be next on the list, and that they have adequate personal protective equipment for the healthcare personnel. They have masks and gowns in order to allow for this reopening without the worry that you may stretch the limited resources thin again. There should be testing in place for COVID-19 cases with symptoms, and there should be contact tracing in place. And this information you should be able to discern from your local public health experts. I think at this point, Robin, we should open it up to some questions that may need to be answered. And in the meantime, I'm going to just leave this slide up here, which I think we've talked about to a great extent, which lists some of the key best practices.
Awesome. Thank you, Ray. I do have a few questions that have come in. I'm going to start with one of the most recent ones because we're talking about return to work best practices at the moment. So you didn't specifically mention temperature checks as part of the symptom check. So you did talk about asking people questions around, have they been sick? Have they had symptoms? Have they been in contact with someone who is sick? Are you also suggesting that we should be doing temperature checks as part of the return to work model?
This is an excellent question, and it is astute that everyone listening and you, Robin, noted that I didn't actually speak specifically about that. I want you to know that I've learned two real important pearls from responding to pandemics. One is to overreact early. Sadly, our government didn't do that. But certainly other governments such as South Korea, New Zealand, Iceland, to name a few, did a much better job of overreacting early. And for that reason, when I tell you to overreact early, I believe that temperature checks might be a way to overreact early. But I'm going to talk a little bit more specifically about temperature checks in a second. I do want to convey to the audience the second pearl, and the second pearl is to make sure that you're communicating very often with your workforce. And I don't care whether you're a large company or a small company, even having daily emails sent out with the latest information and the greatest reassurance to your workforce that somebody inside the company is working hard to keep abreast of the information that's available and is looking out for the best interest of the health and safety of the workforce. So this is something that we call information therapy. And we know that daily bits of information delivered from a trusted source is quite comforting and is normally responded to. Getting back to temperature checks, I worry about who's doing the temperature checks at the entrance. Is there an employee who's now been assigned to do the temperature checks? Because that employee then is subjected to a lot of potential exposure. I then have the next question, which is, what do you do with the waste from the temperature checks? I'm assuming that there's going to be an electronic temperature tool with a plastic sheath, and then the plastic sheath gets thrown away. And you have to be very careful about what you do with the waste product from these temperature checks. The number of cases that are picked up where somebody has a fever and they didn't know it is remarkably small. So an alternative is to actually require people to take their own temperature and perhaps even to record it and report it before they come into work. Now, there's some concern that people obviously need to get back to work and they need to make money. And even if they're sick, they want to come back to work. And so this screening test will catch those people. But of course, we all know that we're all smart enough to know that if we're not feeling well, we want to sneak into the workplace and we know they're going to have, that my temperature is going to be taken. They can take Tylenol 30 minutes beforehand and then perhaps not have a fever. So, you know, what I think is important is to reassure people that they're going to be taken care of if they stay home and they're not feeling well. So there isn't this pressure to try to sneak into the workplace when you're not feeling well. So this is all the information that I can give you. I am actually not recommending to my clients that they necessarily engage in temperature checks at the workplace. But that I do believe very strongly in the attestation, and I think it's quite reasonable to actually have require people to take their own temperature and record that temperature before they come into work, and that can be included in the attestation. But I don't fault any employer. I don't fault any employer that wants to go that next step. They just have to be very careful that whoever's in charge of doing this entrance temperature checking has personal protective equipment, and that they're doing a very good job of disposing of the wastes.
Okay, awesome. I also learned from a previous webinar that on average, an individual will spike a temperature on day 5.2 after being exposed. And so they could technically be positive and contracting the virus and contaminating others until they've gotten that fever. So I think that there are a lot of good reasons to have a broader approach to that. Hey, so you just mentioned PPE, Ray. So let's go back to an earlier question. For someone who doesn't have PPE, would you recommend that they use a HEPA filter from a vacuum cleaner inside of a cloth mask as an alternative?
It winds up actually that the material that's used for vacuum cleaner bags is the most effective way of protecting, commonly protecting yourself in lieu of having, let's say, an N95 mask or a surgical mask.
Okay,
awesome. That material is not comfortable at all. And again, I want you to understand that from my perspective, the mask is actually more protective for other people than actually for the individual person who's using the mask, because what it conveys to me is that if I enter a room and everybody has a mask on, I'm not going to be subjected to an uncovered sneeze or cough. So the main reason why we're using these masks is for that reason, to prevent respiratory droplets, as opposed to trying to make sure that we have a HEPA filter or some kind of a remarkable filter that we're breathing through that prevents us from breathing in the virus. And again, it's not really a good substitute for social distancing. So I should say physical distancing. So if we stay away from people in a safe distance, then even the use of a homemade mask for our purposes is fine. I'm not recommending that people go get a vacuum cleaner bag and cut it up to put inside the mask. I'm not recommending that.
Okay, great. Hey, so you did mention some specific risk factors in diseases like smoking, cardiovascular conditions, and diabetes that put people at greater risk of dying from COVID. A question came in around substance use disorders and people who are they considered to be at greater risk of dying if they're struggling from substance use disorders?
The answer to that would be yes. So any body that is infected with this virus that is already weakened by either a habit that we engage in or a disease or condition that we have places that person at greater risk. When I give talks, and hopefully I'll have a chance to come back and spend time with you around my passionate pursuit to get all people to help each other toward greater health, what we call building cultures of health. all of that is really around this notion that we're only given one sacred vessel to take our journey on, and why we would do anything other than try to protect it to the greatest extent possible is a mystery to me. So every single bit of food that you consume needs to be verified and validated as being healthy before you consume it. I mean, one of the things that made me feel so sad was the notion that the purchasing of snack foods like potato chips is actually up 20% during the pandemic. Since people are not able to go to other places to get a snack, they're buying more snacks. I just encourage everybody on this webinar to shop around the periphery of the market. Generally speaking, if it comes in a box or a plastic bag, it's processed. And generally speaking, processed food is not as healthy as unprocessed foods. And so the vast majority of your intake should be with raw or cooked fruits and vegetables. That's a terrific starting point toward really taking very good care of your body. Obviously, if you have been in the throes of this horrible opioid epidemic, doing your very best to try to extricate yourself from the addiction is essential, and it's especially essential during this pandemic.
Well, Ray, I don't want to cut you off. We do have one more question. I'm going to submit it in writing to you so that we can get a response regarding what we've learned from the Sweden model. But in closing, first, I'd like to thank you. I'm sure that we all learned a lot, and we've got some great food for thought as we prepare our offices to reopen. I would ask all of you to just take a moment to fill out the survey that has popped up on your screen to give us some guidance on what you'd like to learn about next and times and dates that are going to work for you. And I also encourage you, as we think about how we can help people thrive, please plan to join us for our next webinar that's going to take place in May. We'll provide an information sheet with a session overview and the date and time in the coming week. So again, thank you everyone for joining us today. Thank you, Joanne, for pulling this together. Thank you, Ray, for being a thought leader and for helping us to make the world a better place. So I hope you all have a wonderful day, and we'll talk soon.